Thank you, Karen, and hello, everybody. I hope you can all hear me. So I am going to get started, and hopefully I won't have any technical difficulties. So I'm just going to go over the agenda for today. So Karen, we've done our welcome, and I'm going to begin with just giving a brief project background about the CRPN. And then I'm going to move into overview of perinatal mood disorders. I'm also going to talk about the impact of untreated depression on pregnancy and infant development. And then we're going to go over the tools for screening, identifying, and referring for maternal depression. I'm also going to address the gaps and barriers to seeking mental health care, and I'm actually going to reference publication, a research study that was published on identifying barriers to that intake visit. We're also going to go over the resources that are available to you, two of which are in the handouts. And then we also want to leave time for Q&A. What we're going to try and do is actually try to take questions along the way. So I'm going to pause at some point and just ask if there are any questions. I just think it might help instead of trying to come back, to answer questions from early in the presentation. Okay, so where I'm going to begin is at the beginning, back in 2002. So we began identifying the problem through our local Moms First project. At the time, back in 2002, they were being mandated by HRSA to screen for perinatal depression. We completed a study that was entitled Feelings of African American Perinatal Women, and we had to do that first to examine what the issues were before Moms First decided to proceed with rolling out their mandated screening. And what the results showed was that pregnant women scored at risk for depression at higher rates on the Edinburgh postnatal depression scale, which is the tool that we used, than postpartum women. We convened a focus group of providers in the community, and what they found was that providers were very reluctant to screen because there was nowhere to refer to. There were no resources at the time. Screening was also inconsistent. There was no formal screening tool used. No mental health agency, and that's community mental health agency, had specific programs at the time for pregnant and postpartum women. We also found that actually hospitals were no better. The wait lists were very, very long. We found that referrals in general were getting lost. Providers would call and leave a message on the machine and never hear back about their referral. And those wait times, as I mentioned, were very long. They were about 2 to 3 months for women to be seen. There was no follow-up or feedback regarding the referral outcome. And we found also that the systems weren't talking to each other. That is, like between mental health and psychiatry, between them and like the OBs or those that were screening and making referrals. Women were also taking themselves off their medications because by their providers, or doing it themselves because they were afraid of how the meds might affect the fetus. There's also this unique stigma associated with the population. Many women recognize that something is not right. So as a result, they're also very reluctant to bring it up to their OB, who in turn tends to minimize their symptoms as just being normal signs of pregnancy. So that also reinforced that whole stigma. So since 2005, the CRPN, which is the acronym for Cleveland Regional Perinatal Network, has been working within Cuyahoga to address under-identification and treatment of depressed and pregnant and postpartum women. So what this slide does is pretty much summarize how we address the issue from a public health approach while we tackled our goals simultaneously. So what we've done is provided training and technical assistance. We also convened, and it started in 2007, a dedicated coalition for collaboration and coordination, which was known as our Cuyahoga County Perinatal Depression Task Force. We've developed materials to raise awareness, created a network of perinatal mental health agencies, and they are being reviewed annually to make sure that they're following guidelines, which we've established in the county. We've also maintained a data tracking system, and I'm going to share a little bit about that later in the presentation, and provided care coordination to referring providers regarding the outcome of what their referral was. We've also served as a conduit between community agencies and healthcare institutions. So I'm going to move on to looking at depression in women, and also take a look at overview of what those mood disorders are. Just before I do, just want to make sure that there are no questions at this point, just any questions specific to the project that I talked about. Okay.
I don't see any questions so far, Avril.
Okay, sounds good. All right, so depression in women is much more common than depression in men, with the female-male risk ratio roughly 2 to 1. And the higher prevalence of depression amongst women than men is due to the higher risk of the first onset. So Kessler, who I've referenced here, found that these gender differences emerged during puberty, but other experiences related to hormonal changes like pregnancy or oral contraceptives alone didn't significantly influence major depression. He believed that there was a combination of environmental and biological factors. Other data also shows that genetic factors influence the risk of onset and can alter the way in how a person reacts to stressful life events. So we're going to take a look at the perinatal mood disorders, and I'm going to go over each one. So postpartum blues, which is the most common, perinatal depression, which is divided into the prenatal period as well as the postpartum period. We've really tried to shift the paradigm since I began working in this area, because mostly people were referencing, this as being just postpartum depression, but we've really wanted to include the prenatal period, which is just as important. Maternal depression, and lastly, postpartum psychosis. So let's take a look at the postpartum blues. It affects 50 to 80% of women. It's very common. It begins 1 to 5 days postpartum, and it can last up to 2 weeks. Typically, it does resolve without any type of direct intervention. So, many of the symptoms just go away on their own, but it can become exacerbated by isolation and a poor support system. The symptoms are mild, and they include tearfulness, irritability, insomnia, fatigue, and poor concentration. And I'm sure many of us who may have had children or their first child can recall some of these experiences. So depression during the prenatal period, what we find is symptoms peak during the third trimester. It does have a significant impact on bonding. Women experience this guilt and shame that I referenced earlier about the way they're feeling. They recognize that pregnancy is supposed to be a happy, joyful time, and something isn't jiving for them. So they recognize something definitely feels wrong. And I think this is what makes perinatal depression unique from any other type of depression, is this shame and guilt that many women who do experience depression or anxiety while they're pregnant feel. There are also medical complications that can impact the fetus and the infant, and I'm going to speak a little bit more about that later. Moving on to depression during the postpartum period. This is one of the most common complications of childbirth. It can begin as early as 2 weeks postpartum, and most of the symptoms usually manifest around 6 to 12 weeks, although, as I said, it can begin earlier than that. Women who experience this describe feeling incredibly overwhelmed, and some experience obsessive thoughts about that some harm will come to their infant, but this looks very different to postpartum psychosis. Let's take a look at some of the risk factors that impact a mom who experiences depression, either prenatally or postpartum. So women who have a history of depression, who've also experienced depression with a previous pregnancy, who have a family history of depression, who have an unstable support system, who experience stress, and who may have had an unplanned pregnancy but haven't quite resolved that ambivalence about what to do in terms of their unplanned pregnancy. They may have considered termination or adoption and may have not come in for prenatal care, or if they have, when delivery occurs, they don't have any preparations and they're still not quite sure about what their plan is going to be for the baby. And if they do wind up taking the baby home, they're definitely going to be at risk for experiencing postpartum depression. Postpartum psychosis is very different from postpartum depression, even though you might see or read about or hear about some of those cases on the media who call it postpartum depression, but it really is more, it looks more like postpartum psychosis. It affects 1 to 2 out of every 1,000 births, and it typically occurs within the first 2 weeks of delivery. It's characterized also by the acute onset of major disturbances in both thinking and behavior, such as hallucinations and delusions. And it needs to be treated as a psychiatric emergency. So that would require immediate action like hospitalization because of the big risks of suicide and infancy. Maternal depression, which is the last one, can be identified as being either acute or it can become chronic over time. And that occurs particularly if the depression hasn't been diagnosed during the prenatal period or the postpartum period. The symptoms can last up to a year, and risk factors that are associated with maternal depression include economic instability, poor health, stress, unstable support system, and previous history of depression in the family history of depression. So what are the treatment options? It's usually tailor-made to what the mom wants, in terms of looking at the risk-benefit rate, ratios. So looking at medications as being one possible option. Some women choose not to take medication. There are others that do find they need it. And along with medication, there's also psychotherapy like cognitive behavioral therapy, interpersonal, but usually treatment options are a combination of that along with support groups, peer support groups, and sensory therapies like massage and music. So let's take a look at what the impact is of untreated pregnancy on, untreated depression on pregnancy. This has been associated with inadequate prenatal care, poor maternal health, and substance abuse. So we do see moms who typically might be so depressed they cannot get themselves in for their prenatal care appointments. So we see a lot of missed appointments. It could even occur with pediatric follow-up, missing those appointments. And so in terms of substance abuse, we see women self-medicating with alcohol or substances, drugs. So you often will see a dual diagnosis that's presented, but definitely both need to be addressed. Untreated perinatal depression has also been associated with adverse obstetrical and birth outcomes that include things such as preeclampsia, neonatal growth retardation, low birth weight, preterm labor, increased hospital visits, spontaneous abortion, and fetal death. And also maternal mortality is also being associated with untreated depression. So let's take a look at some of the effects of perinatal depression on the infant. Depression can have a significant impact on the bonding and attachment between the mom and her baby. The infant will be at risk for connecting poorly with others and along with the ability to form healthy relationships. This can lead to problems with managing emotions, resulting in anger and behavioral issues, and the need to be in control of their environment. So some of the effects of perinatal depression on the infant to sort of further expand. When you have a depressed mom, the infant will take those negative cues from the mom, and so they will be less responsive to facial expressions from others. We can see a depressed mom who has very little energy to play and explore the environment with their infant. And this combination can lead to the infant growing up to become either angry and hostile or withdrawn and depressed. So the infant can experience significant behavioral and anxiety problems as they grow and develop, and they're also at higher risk for developing depression during childhood. So the effects of perinatal depression beyond infancy, when maternal depression coexists with other risk factors during the baby's first life, the likelihood increases that by age 3, the child will show significant behavioral, attention, or anxiety problems, and the child will be at an increased risk for developing depression. The child will also be more likely to perform poorly on cognitive and behavioral tasks compared to other children. So before we move on to the next section, which is tools for screening and identifying, I just thought I'd check in to see if there are any questions.
No questions this time.
Okay, so I'm going to move on. So when you take into consideration all the things that we have just reviewed, looking at the mom and why it's important to intervene early during the pregnancy to try to avoid the impact on the baby, the bonding. That's why it's really crucial to begin screening as early as possible. So we're going to talk about the screening tool that we use, which is the Edinburgh Postnatal Depression Scale. And I'm also going to refer to the care path that you can use, which I'm going to speak more about, as well as the referral form that we've been using, which there's a sample, which is one of the handouts that you are welcome to use as a sample. So let's begin. So just a quick question. I know that you can't really respond, but just something to think about. So do more women screen at risk on the Edinburgh prenatally or postpartum? So for those of you who guessed during the pregnancy, you were correct. And what I want to share with you is this longitudinal cohort study, which basically followed mother's mood through the pregnancy and after childbirth, and they compared reported symptoms of depression at each stage. So what you can see is that the proportion of women screened above the threshold, which they use the cutoff of 13 on the Edinburgh, as referencing possible depressive disorders. So depression scores were higher at the 32 weeks of pregnancy than in comparison to the 8 weeks postpartum. 13.5% of women scored above the threshold for probable depression at 32 weeks of pregnancy, as opposed to 9.1% at 8 weeks of postpartum. And so more mothers moved above the threshold for depression between 18 weeks and 32 weeks of pregnancy than between 32 weeks of pregnancy and 8 weeks postpartum. So the next slide I wanted to share with you was just to reference Smith, Goodman, and Hennigan, which are all great studies in terms of looking at obstetric and pediatric practices, how they conducted their screening. So studies that were conducted in those practices reveal that a strong majority of perinatal patients who screen positive for depression are not recognized by the provider, meaning that had they not actually screened, the provider would never have known that the mom was actually depressed or at risk for depression. And previous studies on depression in primary care settings have identified lack of time, lack of comfort with mental health, and lack of mental health resources available for referrals as barriers to physician screening, which is something I referenced at the beginning in those earlier slides that I shared with you, is that the reasons that providers weren't motivated or didn't feel that they could screen was just they didn't feel that they had any resources to refer to. And lack of time, when when we take a look at the Edinburgh, you'll see that it really can be completed within under a couple of minutes. So I think, thank God, since we started doing this, we've gotten beyond these rationales, but these are definitely things that you could run into in interacting with some of the healthcare providers that you might work with. So just making you aware of that. So let's take a look at the Edinburgh. This is one of your handouts that you can download and use. So the Edinburgh has been tested for reliability and validity, both prenatally and postpartum. And as you can see, it's a 10-item questionnaire. It is a screen. So what it does tell you is that the mom is at risk. It is not a diagnostic tool. If the mom does score above, and we typically use the cutoff of 12 and above. Some use 13. I've even had some who use the cutoff of 10 and above. So that's just something that you can determine within your own clinical practice how you want to approach this. And I'm going to go over the scoring in a moment. Just a couple of other things to pay attention to. So if you read at the top, it says, in the past 7 days is highlighted. So when you introduce this to your patient or your client, you want to make sure that they're aware of that they need to respond to each question within the past 7 days. So it screens pretty recently. You'll also notice that some of the questions are asterisked and some are not. So that impacts the scoring. So for the non-asterisk, so for example, number 1, I have been able to laugh and see the funny side of things. That would be 0, 1, 2, and 3. So if it was as much as I ever could, that would have a value of 0. If you look at number 3, which is the asterisk question, I have blamed myself unnecessarily when things went wrong. Yes, most of the time. Yes, some of the time, not very often, no, never. And the patient selected yes, most of the time. That would be a value of 3. So you would add up each value for each question, and then if the total score is, like I said, we use 12 and above, then that would mean that the mom is at risk, and she needs to be further evaluated by a mental health provider. The other question that is also the one question that is important is question 10. That is the thought of harming myself has occurred to me. And when we take a look at the care path, I'm going to share what the responses to that would be. But obviously, if the mom says yes quite often, that would qualify as immediate, intervention. She would need to be evaluated to make sure she doesn't have a plan, and that she, and to determine whether she is high risk or not. So let's talk about the care path, which is really like the meat and potatoes of the whole screening and referral process. When I first started, yes.
We have a question about the Edinburgh screening tool.
Sure, I'll go back.
The question is, I work with several OB providers who have questioned the validity, utility of the Edinburgh screening tool for use in the Black community. Could you speak to this, and do you have any thoughts or recommendations to express to those with these concerns, as we are continuing to use this tool in our clinic, which serves primarily women who identify as Black or African American? Thank you.
I'm trying to look at the question, so sorry, so I can also just see that I didn't miss anything. Okay. So let me just repeat the question. Was a question that several of the OBs have questioned the validity of using the Edinburgh prenatally. Was that prenatal or postpartum? Right. Okay, well, there are, and I don't, I can, once we're done, maybe email the reference, but there are studies that have shown the validity of the Edinburgh prenatally, and that it has actually a very high specificity. So that has been addressed.
In the Black community? In the Black community?
No, I wasn't sure if the question was for the Black community or just in general.
No, she's saying that there are concerns that the Edinburgh screening tool doesn't serve well for the Black women that identify as Black or African American. That's what she's asking.
Yeah, and there are definitely, that is something that I have heard, and I, in terms of when we've had conversations about this, we don't have anything that we have as an alternative that's culturally sensitive for the African American population. One of the main reasons for the Edinburgh is that it doesn't pick up symptoms of pregnancy. It only picks up symptoms of depression. So which is one of the main reasons that it's like the kind of gold standard to use the Edinburgh. I am not aware of any other tools that are culturally sensitive for the African American population. So unfortunately, I'm not. That is definitely something I think that we should be targeting and developing a screening tool that's more effective for the African American population. I know actually the tool was developed in Scotland, in Edinburgh, Scotland. So, even many people who, some of the terminology, some of the questions don't make sense and need to be explained. And it all depends on how you're administering it. If you are able to ask the questions to the patient with, and is able to explain some of the, the terminology, or, kind of translated, as it were, that would be great. Probably would be the best option. But for the mom to just self-administer, that definitely can affect how the mom's going to respond to the questions. So I know that is a definite barrier to using this as a screening tool. I'm sorry.
The next question about the screening tool, Avril, is there a reason why the screening is recommended to be completed during 24 to 26 weeks?
So the symptoms peak in the third trimester. So I'm going to get to the care path that does go over the screening. When are the best times to screen? So hopefully I can answer that question when I get to the care path.
That's it.
Okay, yeah, I'm just trying to get to my next slide, but I seem to be frozen. Okay, so as I was, before I started answering the questions, I think I was addressing why do we need a care path? And what would happen is when I first started training back in 2005, we didn't have a care path. And I would train and really when I would follow up, many of providers hadn't implemented screening. So came up with a care path, which basically says how to screen, what to use, when to screen, what do you do if the score is elevated, what if the suicide item is checked, how to make a referral, when is the referral appropriate, what if the client refuses, and also trying to get follow-up information. So I developed the care path. This care path was used from when I did previous statewide training that was back in 2017. So I know the question you asked earlier, a few minutes ago was why do we screen between 24 and 26 weeks? That is during the third trimester, which is when symptoms tend to peak. However, you can also screen anytime there is a concern. There are other institutions that are choosing to screen in the first trimester, the second and the third, and that's fine. I think if you just want to have a consistent universal approach, selecting that third trimester, because we know that's when moms typically might feel depressed. So that's why we do focus on that time period. The postpartum would be after the blues have gone away. So we know by 4 weeks postpartum, that's when the blues have gone away, because we want to try not to hit the blues. So that's why we recommend after 4 weeks. And as I said, anytime there is a concern is also fine. So you may want to screen 2 weeks postpartum, or you may want to screen, as I said, in the first trimester, or even the second. It's entirely up to you. I mean, this is like a very flexible care path. When I go ahead and do provide a training, I send my sample to the agency that I'm training. They modify it according to their needs. So if your need is, okay, we're only going to screen in the first trimester, that's fine. Just, do whatever makes sense to you clinically. The client could refuse a screen, and you would want to document that in her record and try to screen it at the next visit. But we don't see that happening very often. It's very rare. We also rely on the fact that it's all about the delivery. So when you present this to the mom, you want to present it as being that, we believe in providing good clinical care to all our pregnant women. looking at how she's doing both physically and emotionally. So we want to ask you some questions to get a sense of how you're doing. And if you're needing any extra help, that's what we're here for. And we can, make a referral if you do need that extra help. So it's all about the delivery. So going on to the screening results, if the mom scores 11 or less, you can provide the full mom's resource and then rescreen at later point if necessary. And that's also one of the handouts that I'm going to go over. If she scores 12 or more, then that's when you discuss the need for further assessment and referral, and you would document that in the patient record. The client may refuse the referral, and that happens that's very common. And if she does, then you would document that in her record and provide her with a full mom's research. And then you want to just review the differences between the baby blues and perinatal depression, and then address the issue at the next visit. Some of you might have like an immediate step on site at your agencies where you might have social work, you might have mental health, you might have psychiatry. And so that is definitely an option. We do see that where the OB sees the mom and then refers to social work. Social work does an assessment and then goes on to make the referral to community mental health. The mom obviously also has the option of a self-referral, so she would just need that mental health agency's contact information, and she can call them and make the appointment. What we're doing typically is making that community mental health referral. We've developed a referral form that I'm going to just show you what it looks like, and as I said, you're more than welcome to use the template for it. That's also one of your handouts. And then that would be completed. There is a consent on there that the mom needs to sign because you're sharing, HIPAA information with the mental health agency. Then the full mom's resource would also be provided. Let's look at that question 10 that I flagged, which would be if the mom responds to hardly ever, sometimes, or quite often. You would also want to include, it's not on the Edinburgh, but you would also want to include a homicidal risk question, which is, have you had thoughts of harming your others, in the past 7 days? So it can look a lot like how you would ask that suicidal risk question. It just would be harm to others. So if the mom has checked off in either of those 3 responses on question 10, has also answered yes on the homicidal risk question, then you want to discuss her responses and the need to assess her safety. If you're able to coordinate an on-site psychiatric evaluation, I would definitely encourage that. Many of you might be referring to your mental health crisis hotline for a phone evaluation, and then to assess whether that mom is safe, or needs to be taken to the emergency room. And you would document the safety plan in the patient record. I'm just going to check in if there are any questions about the care path at this point. Karen?
Doesn't look like any questions. Just give me a second.
Okay, all right.
Wait a minute, maybe just a second. Like why should we wait for the symptoms to peak?
Because if you are screening and the symptoms haven't peaked, then you would get, she wouldn't score at risk.
That's the only question I have. So wait a minute. Wait just a second. Kind of difficult. Is there a reason screening is? Oh, never mind. That I've already read that one. Well, that looks like the next one. Looks like the only one.
Okay, all right. I hope I answered that. Yeah, because basically if you're scoring, I think the whole point, so the point of the care path is trying to be consistent in your screening intervals. So if you like I said, if you feel the mom is presenting with some risk factors in the first or second trimester, it's fine to go ahead and screen her. The point of the care path is just to be sort of have a universal approach to screening. So screening at the third trimester interval versus trying to screen at the first trimester when what the literature shows us is that we don't typically see symptoms in the first trimester or the second trimester. So I hope I answered that question.
One more question. Is there a cost for the use of the Edinburgh screen, or is it able to be reproduced without copyright concerns?
Yes, the answer to that is there is no cost. It's in the public domain, so you can make as many copies as you would like. I'm sorry, I forgot to mention that.
I think that's it, Akron. Thank you.
Okay, so in terms of mental health, community mental health agencies, when when our project started, we had 0 perinatal mental health agencies. And actually, after we began, we started with 1, and now we've grown into 5. Several of ours offer a combination of in-home mental health assessments and treatment and other services, along with agency-based services. And then some only offer agency-based services. So just something for you to be aware of. And when I go over the directory, we have set the directory up to include, what kinds of services are provided. So hopefully that should help you. So this is our referral form that we use. We actually started, with how it looked back and when we first started to what it looks like now, recent. In fact, I just, you have the very updated version, the 221, and there's not a whole lot that's changed, but that's the handout that you have. And so it is a PDF fillable, which is really nice for the providers. And if they can figure out an electronic signature to use, that makes it even better. But most of our providers are in fact, pretty much all the providers that make referrals to one of our 5 agencies uses this form. They don't fill out everything, but we encourage them obviously to fill out as much as possible. But, some of the main things that will determine the referral is if they prefer in-home or office-based services. That's a biggie. We also want to make sure that they provide their information, so they provide a name as well as their email or fax. And it's because what we do is get the monthly data of all those referrals so I can provide feedback and care coordination to the provider who made the referral. And I'm going to show you more about that in a few slides. But this referral form really is just, has a lot of great information. Obviously, as I said, some of the information is more important than other. The mental health agency needs to know, what the medical insurance is or the Social Security so that they can at least get going, open up a case and get going on the referral. So that is very important. Obviously, the Edinburgh score is important. But like I said, we don't have like 100% always completed referrals, and that's okay. So it's a 2-sided page, and this is what our second side looks like. It's actually listing all our mental health agencies that are in the CRPN network. So we do need to keep updating this because numbers change and emails change. But we also offer a little descriptor under each one, in terms of what kinds of services, like Belfair provides office-based services, and they're covered by Medicaid and some select commercial insurance, and just a brief information about the location. We also include our frontline mobile crisis number on there because obviously, there are referrals that do qualify under that homicidal and suicidal risk. And in fact, our frontline mobile crisis goes ahead and refers back to, one of our 5 mental health agencies for follow-up after they've assessed the client. Yeah, I think that's about it. I don't know if there are any questions. Like I said, this is just, I just wanted to show you an example of how we use it. If you don't want to use it, that's fine. It's up to you. So to summarize how the whole screening and referral works, this is just an outline, and this is the process that providers get trained on. So on the top left, you see the referring provider screens the mom at risk, and then that will trigger the conversation with the mom about the services. The provider refers to one of our 5 mental health agencies. All our agencies adhere to guidelines. So we've created guidelines in the county that stipulate the client needs to be contacted by the mental health agency within 72 hours upon receipt of the referral, and also offered an intake appointment within 1 to 2 weeks after the contact is made. We really have worked very hard on to reduce those 2 to 3 month wait times. So we've been really successful. I think we've been pretty successful in, reducing the wait time for that intake appointment. So the receipt of the referral form indicates that that this is a maternal client referral, and the mental health agency begins outreach to engage the client. Ideally, the agency connects with the mom and schedules the assessment. And the largest barrier, of course, to prevent this is that the mental health agency can't reach the client because the numbers aren't good, or the address, they'll send letters, outreach letters, the address isn't good, or alternatively, the mom declines the referral. But regardless of outcome, the CRPN provides feedback directly to the referring provider on a monthly basis. The other thing that our agencies all do is offer a psychiatry appointment within 3 weeks. So let's talk a little bit about the stigma and how this impacts those barriers to seeking mental health care. So stigma has really provided a lot of discomfort for the mom in sharing with her provider that she's feeling depressed. The mom we've heard feedback that moms feel that they're being labeled as crazy, and with perinatal depression being lumped in with more severe diagnoses, that really just reinforces the way the mom feels. There are some, definite cultural issues. Some cultures, don't believe in sharing with outsiders, keep it in the family. There's a mistrust of the system. What are you doing with this information? There could be a fear that this could be reported to Department of Children and Family Services, and fear of just having custody being removed. There's also a barrier with that mental health agency being in a separate setting, and there could be shame and discomfort going for appointments there, along with fear of taking medications. In terms of transportation, this has also been recognized as being a huge barrier. The mental health agency might not be on the bus route, or it takes a lot of energy when you're depressed and pregnant to get your appointments. Along with childcare, some agencies might offer childcare, but many do not. And also the wait time. This can be a huge challenge to call back to set the appointment, wait time for the appointment, along with, just waiting at the office. So these are all definite barriers that I think you just need to, be aware of in terms of, trying to support and encourage your clients to following through with treatment. So I'm just briefly going to touch on the study that we did, which our objective, this was attendance at mental health appointments. by referred pregnant and postpartum women. The objective was to identify characteristics of pregnant and postpartum women who were associated with attending a mental health intake visit after the referral was made. Based on the clinical experience and literature review, women with more mental health concerns and more social supports would be more likely to attend. So that was our hypothesis. What we did was we actually used our maternal behavioral health referral form and used, I'm going to go over the data that we included, but we basically analyzed the data of those women who were referred to one of those mental health agencies in Cuyahoga County for treatment. And what we looked at was age, socioeconomic status, marital status, pregnant or postpartum, the infant's age, the reason for referral, the Edinburgh score, suicidal risk, homicidal risk, medications taken, and the perinatal mental health agency site, whether it was a agency-based services or in-home services. So we tracked the data of 647 women that were referred to one of the CRPN's mental health agencies. We actually had couldn't have been more perfect almost. We had a total split. We had 323 who attended their intake appointment and 324 that did not. So these were the factors that predicted whether they would attend that first mental health appointment. If they were referred to the site that offered in-home intake visits, if they were lower socioeconomic status, and also if perinatal loss was a reason for referral, or it was a self-referral, so they requested the referral themselves. Something I need to point out that Medicaid is the only insurance that covers in-home visits. So commercial insurance does not cover in-home visits. And that also, so you can see why low socioeconomic status could have been one of the factors that predicted attendance, because all women who were able to make their in-home intake visits were covered by Medicaid. So the factors that did not predict attendance was maternal age, marital status, pregnant or postpartum, psychotropic medication use, other various reasons for referral, or more than one reason for referral. So I thought I would just share that study, and it is currently on our website if you want to read more up on it. Now I want to move into our For Moms brochure, which I believe is one of the handouts that was just the last one that was uploaded while we've been doing the presentation. And then the other resource is our mental health services directory that was just created statewide. So I'm hoping that you will be able to find resources for moms that live in your region, and we're going to go over that. So this is what the For Moms brochure looks like. There are some generic resources on stress, depression. Poem is on there, healthcare abuse and violence. These are, statewide numbers. And the second page I think is very relevant because it goes over what the blues is versus postpartum depression and helpful tips. So that is the For Moms brochure that I was referring to on the care path that you can use. You can download and print it off. There are also 2 screening questions that are on there. Those 2 screening questions are put up by the U.S. Preventative Task Force that can be used screening. And so I am now going to, this is where it's going to get tricky because I'm going to close off out the PowerPoint and open up the services directory. So if you could just give me a second. Okay, can everybody see that? Okay, so.
I see it, Abra.
Okay, good. Okay, good. Okay, so I'm just going to kind of whip through it a little bit. So you may or may not recognize these agencies. I want you to pay attention to how we have set this up. So for example, the first one, which you see is Access Counseling Services. We try to identify a contact person at each agency, and we also use email as a direct contact method. We've also included phone numbers and try to reference what they, that you can use them like here for the intake or for their operator. We've included fax number, and we've also included the counties that the mental health agency covers. So that should help you along with the region. So the first one is the Summit region, and those are the agencies that it covers. We have included the services that it provides. And we've also, let me just go back, office locations. So we've listed as many as we possibly could, the office locations for each agency. So, and this was just created like a month ago, so everything's current. So under office locations, we've included services. So that would be, do they provide outpatient or agency-based services versus inpatient or community-based? And we'll look at an agency that does community-based, so you can see many, because of COVID, are providing telehealth. We've included same-day walk-in, case management. Hold on one second. Psychiatry, counseling, MAT. We've also included the groups that they've served, birth to adults, or if they don't, we've listed whom they serve. We've included payments accepted, Medicaid, Medicare, self-pay, sliding scale, and private insurance. We were at first going to list all the private insurances at each agency, but it was just too much. And it changes. So we encourage you to call or contact the agency to establish what the private insurance options are. The next agency is Libyan Health Centers of Akron. Same thing. This covers Summit and surrounding areas. And here, for example, groups we've had 4 years to adult. So each agency really has exactly the same outline. So you should be able to find all the information under each section. So we have Allwell Behavioral Health Services. I've included Applewood Centers, that's in the North Coast region. That's happens to be one of my 5 mental health agencies, along with Belfair is also included in the North Coast region. Catholic Charities, Diocese of Cleveland. This covers quite a wide area. It's got the whole North Coast region that includes Ashland, Cuyahoga, Geauga, Lake Lorraine, Medina, Summit, and Wayne. We might have some overlap too in many of these agencies. So those are all the office locations, the services that are provided. So here you see in-home community-based is also listed there. Cedar Hill Ridge Behavioral Health Services, they cover Appalachian region, which is Morgan, Muskegon, and Guernsey. Chrysalis Counseling Services, they're in Heartland and Appalachian. Cleveland Clinic Union Hospital Behavioral Health Center, that's Heartland and Appalachian. Coleman Professional Services, they're in North Coast and Appalachian. Community Behavioral Health, they are in the Summit region. Crossroads Center, that's in Summit. Family Life Counseling and Psychiatric Services, that's in the Heartland and Twin Valley regions. Family Recovery Services, Family Recovery Center, Heartland and Appalachian region. Family Resource Center of Northwest Ohio, that's in the Northwest region. Far West Center, that's in North Coast. First Step Home is in Summit. Hopewell Health Centers, that is in Appalachian. Integrated Services for Behavioral Health, that is Appalachian and Twin Valley. Life and Purpose Behavioral Health, that is Appalachian region. Maumee Valley Guidance Center, that is in Northwest region. Mental Health America of Ohio POEM, which is statewide. They are online, so they are statewide. Those are peer support services and the support line. Meridian Healthcare, which is in Heartland region. Minority Behavioral Health Group, North Coast and Heartland regions. New Life Counseling, which is Heartland, North Coast, and Appalachian regions. They say they can serve 88 counties with the telehealth option. Ohio Guidestone covers North Coast, Northwest, Twin Valley, and Heartland regions. And I've listed each. This is set up a little differently because I listed each county for the contact number, so, and email. Okay, so let me see. That is Recovery and Prevention Resource of Delaware and Morrow County. That's Twin Valley. Recovery Centers, Inc. That is, this serves all of Ohio residents, although they listed green or Summit region, which is probably just where they're actually physically located. Scioto Paint Valley Mental Health Center, that's the Twin Valley region. Signature Health, North Coast region. Solutions Community Counseling and Recovery Centers of Warren and Clinton, which is Summit County. Summit region. Southeast Healthcare is Heartland, Twin Valley, and Appalachian regions. TCN Behavioral Health, Summit and Twin Valley region. And the Counseling Center of Wayne and Holmes County, which is the Heartland region, and the ZEP Center, Northwest region. And that is it. So for more detail regarding those private insurance options, please contact the mental health agencies directly. Does anybody have any questions about the directory? And I hope you're able to download it.
Let me check that. It doesn't look like there's any questions. No,
Okay.
there are none.
I'm hoping that you are able, that the resources are going to be helpful to you. I mean, we put a lot of careful thought and reached out to as many people. We had meetings galore, and at the time pre-COVID, we visited 5 regions, had meetings. We had conference call follow-ups for those who didn't make the meeting. We sent out questionnaires, requesting who was interested in being. Oh, I beg your pardon. We did a training for them as well. This was it last year? I can't remember. Was it this year? Last year, right, Karen?
Yeah, it was
training.
Yes. For the end of last year.
Yeah. We did the training for, it was June, that's right. We did a training for mental health agencies that were included in the infrastructure building that we did in the first year to train them on setting up mental health services for pregnant and postpartum women, how to create that infrastructure. And I used somebody from Applewood Services here locally to help me co-present so she could talk about her, experiences in how they did it. And it was very well received. So, so now because we paid attention, we listened to the feedback we got like 2 or 3 years ago when we did the trainings across the region, and folks were like, well, we don't have the resources. So we hope now that you do have the resources to make these referrals to, and hopefully this will, keep updated too. Okay, so I'm gonna finish off and go to the last part.
We'll have this, can I just say something really quick, please? We'll have
Sure.
this downloaded to the Maternal Depression page shortly. So if they need to access this document, that's where we're going to house it. Thank
Okay.
you.
Sure. So I'm just going to finish up, and it will also be available if there are any more questions. Just to go over how we do the data tracking. We developed it in 2010. We collect monthly data from the mental health agencies. As you can see on the Excel sheet, we collect the data of referral, the client's name, so date of birth, race, ethnicity, zip code, who made the referral, contact for the referring provider, and name of referring agency. And we also have that key intake code. So Y means the intake was completed. If you look on the section under K, pending means it's pending from 1 month to the next because they're still providing outreach to connect with the patient or the client. W means withdrawn because the client declined services or they could not connect to the client. S means that the intake is being scheduled, in the process of being scheduled. So what does that all translate into? Because we have to measure our project outcomes. So we have been collecting how many referrals have been made to one of our 5 mental health agencies. So I just wanted to share the data over the last 9 years. We've seen a drastic increase in referrals to our 5 perinatal mental health agencies. And as a result, we've had to expand. So that's how we've gone from 1 perinatal mental health agency now to 5. So as you can see, the total number of referrals between 2010 and 2019 was 8,919. And that is a 609% change, which is pretty incredible. And as you can see, 2019, we, was kind of the highest number that year was the highest that was made. We did see a drop in 2020. I haven't finished putting all that data together, mostly because of COVID and everybody did switch to telehealth. Although it was interesting because we did see an improvement in our intake rates, that, providing telehealth care definitely has a positive impact in terms of, that mom making her intake appointment and connecting with the mental health agency. So the next slide is we track our intakes. We began doing that in 2012. What that means is, like I explained, the Y means that she made her mental health assessment or intake appointment. We had 3,524 women complete their intake assessment between 2012 and 2019. And the next just shows you how much care coordination is provided each year. We began doing that in 2017. So our consent form allows our perinatal mental health agencies to provide that basic information to me on the outcome of the referral, and then I go ahead and communicate that back to the referring provider to ensure they're receiving monthly updates on the moms they refer. And we do it mostly by email, sent securely. We've also seen quite a drastic increase in our care coordination, as you can see. So just a little bit of breakdown on our 2019 data. I also collect quarterly screens, and we had a total of 23,180 screens in 2019. It's broken down by agency. The first one is BBPAT, which is Bright Beginnings Parents as Teachers. They're a home visiting program. The next one is Cuyahoga County Board of Health, the newborn home visiting program. Metro Health, one of our healthcare institutions. Then Moms First, another home visiting program. University Hospitals, which is that darker blue. And then Cleveland Clinic, they happen to screen the most. As you can see, these are our referral sources. The 3 largest bars are our healthcare institutions, and several other are making referrals. Some have had trainings. Most have had trainings and have a protocol, but there are some who haven't. I'm just gonna move on just to show you one more. This is how we collect data on our actual mental health agencies. We do that also, we collect that and analyze that every quarter. So those are our 5 agencies. It's interesting to look at our intakes. Our intake rates are the highest with those agencies that provide in-home visits, in-home services, and that's Applewood and Ohio Guidestone. So what does this data mean? Basically, the impact for 2019, looking at our Edinburgh screening and referral efforts, we had 13,937 births in Cuyahoga County. So that just kind of gives you an idea of how many screenings were completed, 23,180. And so that works out to be an average of more than 65 screenings per day every day. We had 1,362 women referred to one of our 5 mental health agencies. That works out to be 4 women per day every day. And 522 women received treatment for their depression, and that works out to be an average of a little more than 1 woman per day every day. The last slide I just wanted to show you, we started GIS tracking, and what you see here is this is the map of Cuyahoga County with the zip codes, and what we have is those women with the darkest purple are the highest number of women that were referred, residents that were referred for maternal depression to one of our mental health agencies. And this is, you're looking at an infant mortality map by zip code. Also the darker green shows the highest numbers of infant mortality, which is actually referred to as like the C curve in the county. So what we did here was, using GIS mapping techniques, we visually are demonstrating how the relationship between maternal mental health and infant mortality. So we've overlaid the maternal depression referrals that I showed you in the 2 previous slides with the infant mortality maps. So you see the darker, larger purple circles overlaying the darker areas of the map, showing the relationship between the 2. So we have time for any questions, any thoughts?
Yeah, we have like 10 minutes left. Any more questions from the audience members? I'm looking, I don't see any. Maybe we could talk some about what do you think our next steps are going to be? What would be the next best steps for the state to help out the providers after this resource directory is, since the resource directory was completed? There were some concerns, I thought, when we were meeting around the state before COVID about the, what do you think needs to be, what are your thoughts about, I think it was more like in rural areas where they were unable to even take women because they didn't have the services. What is your thoughts about those kind of situations, maybe like in Appalachia? What could we do as the state? What would your recommendations be as the state to address that?
Are you asking the audience, Karen?
No, I'm asking you. What do you think?
Oh, you're asking me. Oh,
from our things we did around the state, what do you think? We had a lot of coverage of the state, but there were some areas that we didn't get to cover.
I think transportation was like a big barrier in the rural areas, if I remember correctly. Was that like for women to be able to get to their appointments? They also, one of the big barriers was the services weren't as available like every day, or there were wait lists. It was a long time for them to get, for them to get an appointment.
Correct. Those are some of the Yeah, in those areas.
Right.
So for the audience, what do you think should be next steps? If you could put them in the I guess the question box. I'm thinking, what do you think would be the next steps to help each community, each individual community, because the needs are different also across the state, to help in your area to address maternal wellness? We could use those comments in our planning.
Yeah, definitely.
Let me see. I think we got something. Question. It looks like somebody said, so far, has data been collected or reviewed? You're collecting some data, aren't you? In your county, right?
Yeah, so the data that I shared with you is just for Cuyahoga County. They may be, as far as I know, and I'm not 100% sure, I know Summit County was that. So our project, I know, is being duplicated in the Summit County area. They have a similar type of project, and they've also duplicated in Lorain County. I am aware that they had been collecting data in Summit County, but I'm not aware of any of the other counties that have been collecting data. So I don't know, but I mean, depending on what your next steps, within your own agencies, what you want to do. Much of this presentation was just kind of giving you some ideas, some thoughts. If that's something you want to take on, is setting up your own database within your county to try to track referrals that you're making, or you can partner with your mental health agencies and collect the data together, as you probably would be referring to those mental health agencies. So
and on a state level, I know there's some data being collected, but I don't know if it's directly concerning maternal depression. I would have to look into that. And if you wanted me to, you can send me an email and I can ask our research people, do they have that kind of data statewide? Also, there's another question about how has COVID affected maternal depression?
Yeah.
COVID has, what have you seen, Abra?
Well, what I'm seeing is, there's definitely been an impact, I mean, I'm not basing it on studies, it's just kind of word of mouth and reports that I hear, but definitely have seen an impact on, pregnant women. And because there's a lot of anxiety about, getting COVID while you're pregnant as well. So, but what we have noticed, as I mentioned a little earlier, is by switching to telehealth, the clients seem to really like it. We've had an amazing response in terms of, clients wanting to engage with the mental health agent, with the counselors, and wanting to engage via telephone or, however the telehealth services are being provided. So it's really been interesting. I mean, there's been some who don't like it because of the privacy issue and, having to, not be able to find, a private place to do it. But generally speaking, I would say that it's had a positive impact in terms of, moms following through with their therapy.
And I think the same thing. I don't think we have any kind of data, because data usually is collected years in advance. But anecdotally, just like working with my colleagues, seeing my family, COVID has affected many of us. I think we're going to see a lot at the end of this, more anxiety with women. There's been reports of more domestic violence. I mean, there's lots of things that affect women that's going to be, and women is a topic here, but just individuals in general working through this COVID phase, because life is so different. We're isolated. it's going to be interesting to see what kind of data we get later on about COVID. Let me see if there's any other questions. Oh, I see. Looks like that's the last one.
Okay.
Wait a
Yeah, I'm
minute.
not finally have been able to open up the box for the questions. Sorry, it took me a while to do that.
Yeah, those are some interesting questions.
Okay.
Yeah.
I'm curious, were folks able to download the handouts, and just want to make sure everyone was able to do that.
If one person could say yes, that would be appreciative. You were able to download 5 handouts that Avril provided. If not, we can make sure you get them later. But they should have been.
Okay. I guess if you couldn't, just let us know. That's probably a better way too. Okay.
Yeah.
Okay.
Well, they said yes. They were able to. They answered yes.
They did? Okay.
Yeah. Yeah, I got lots of yeses, so thank you.
Good.
So as a reminder, Shar put in the chat window that you will be getting your, after you do the evaluation, you should be getting an evaluation after the session ends. And shortly after that, you should be getting your certificate. If you do not get your certificate, please send the comment to the mental health, maternal depression training mailbox, and we will get that addressed. So we want to make sure everybody gets their CE2. And also, we're going to be sending out another save the date because Avro's going to do a second training in the evening for people in the afternoon from 1 to, what time is it, Avro? Let me see.
1 to 2:30. So it's the same training. We're just repeating it for people who couldn't make this one. So
Right.
if any of your colleagues or anyone you know might be interested, that Karen has a. How would you like to handle that, Karen? Just if they.
I'm going to send out another save the date, and they can forward that to anybody that they think might be interested.
Sounds good.
Okay.
Okay.
And so we thank everybody for attending the Addressing Maternal Mental Health Best Practices in Screening, Identification, and Referrals.
Thank you. Thank you.
And we'll send another save the date out either later this week or very shortly for others to register.
There was a question, how do we do evaluation and get certificates?
How do we what?
The question just popped up. How do we do evaluation and get certificates?
Well, Shar said that after this is over, they should get the evaluation. And then the certificate should come to them after they've completed that evaluation.
Okay, I hope that answered your question. You sent that.
Oh my God.
Okay.
So, I think we could go ahead and close. I'd like to thank you, Avril, for providing that training for us and all the work you've done, all the hard work you've done we've been working together about 3 years. We really appreciate it. We've gained some progress in maternal depression, trying to cover the state and see what their needs are. So you are appreciated. Thank you so much.
Thank you so much. Been an absolute pleasure working with you too. I've really enjoyed it.